So today we are very grateful to have Lorinda, who is a person with lived experience, and Julie Reeder, who is an OT. Julie is a registered nurse specialized in acute neurosciences nursing. She spent her career working with persons with stroke, brain injury, and spinal cord injury, and is a certified neurosciences nurse. We also have Dr. Hardeep Kainth joining us as well to speak on pressure injuries, and he is an assistant clinical professor at the U of A and the medical lead of a spinal cord injury program at the Glenrose Hospital in Edmonton.
Welcome, everybody. Thank you for joining us for this. We're going to do a little panel between Lorinda and Hardeep and myself about Lorinda's story of pressure injury prevention, management, and recovery. Thank you, Casey, for introducing us. I think I feel pretty good about my introduction, so I'm not going to say anything more. But I'm going to pass it over to Lorinda to tell us her story.
Hello, everyone. I feel very lucky to be at this conference today and to share some of my lived experience with a spinal cord injury, but also the dreaded pressure sore that I got. I became a paraplegic on August 3rd in 2009, just from a camping accident. And after I recovered from the initial shock of living with a spinal cord injury and all the big changes that resulted from my injury, I was living a pretty well and adjusted life. I was active. I was going back to university. I was sit skiing in the winter. And one weekend in July, I sustained a pressure injury from a metal dock, like it was a metal grated dock at a friend's cabin. And for the next year, I spent recovering from that pressure injury and just learning how serious pressure injuries can become if they're not taken care of right away. So I'll just be sharing a little bit about my journey with that. And there is the photo in the bottom right of that eventful weekend.
Thanks, Lorinda. I'm going to ask you to hop in a few moments, I think. First, I think we'll just very briefly talk about pressure injuries and why they happen, why they're a more serious problem or higher risk for folks with spinal cord injury, and how we're going to prevent them. So I know everybody on this call already knows this, but just, very briefly, a pressure injury is the localized damage to the tissues caused by pressure or pressure and shear. This is usually as a result of tissues being squished between a bony prominence and a surface, but also can result from medical devices or other types of devices as well. So here's your image of the devices. So why are pressure injuries a problem for the general population? I like to think of it as it's a balancing act and an equation between the pressure that is applied and the tissue tolerance that is within the person whose skin we're talking about. So the top half is the pressure that's being applied to the person, right? We have our mechanical boundary conditions, which includes the mechanical load, the magnitude of it, how much actual pressure do we have, the duration, how long is that pressure there for, and what direction is that pressure coming from? Is it coming from the side, causing shearing? Is it from a device? All of that stuff makes a difference. And then resisting the mechanical boundary conditions, we also have tissue tolerance. So things about the person whose skin we're talking about can resist that pressure for a certain amount of time, a certain amount of pressure, and the more tolerance they have, the better they can resist that pressure. So that the things that make tissue tolerance increase are good nutrition, a younger age, good tissue perfusion, no chronic illnesses, normal skin and body temperature, and we're talking like degrees here, degrees of degrees, moisture, not too dry, not too wet, very Goldilocks moisture, and having an adequate amount of muscle mass. So then if we take this equation that's kind of there for the general population of human beings, and we add in folks with spinal cord injury have a lot more risk factors that increase the down blue arrow and decrease the up green arrow, which means they are at even higher risk of pressure injuries. So one of the things that is sort of not listed here, but that makes the blue arrow worse is that people with spinal cord injury often have sensory deficits. And when you can't feel the feedback that's coming through your body to tell you that the tissues are in jeopardy, there's a likelihood that one of us is going to make a mistake, that we're not going to respond quickly enough. And so that increases sometimes the magnitude, but often the duration of the pressure that's being applied. Then we have all this stuff that happens to people in early hospital or even pre-hospital. So like if there's a use of a spinal motion restriction or C-spine precautions, a spine board in the field or in a merge, if we're applying cervical collars or orthotics using medical or adaptive devices, those things can lead to device-related pressure injuries. And in general, the use of inappropriate equipment or the lack of appropriate equipment can increase this risk of adding the mechanical load to this population of patients. Then on the bottom, if we look at what are the things that decrease tissue tolerance for persons with spinal cord injury, I mean, we have so many, but here are the big ones. There's potential for microvascular changes right at the tissue level, at those capillaries. There's possibility that even if we had normal blood flow, it's still not quite as good. Autonomic dysfunction can have an effect on a lot of these things. It could have an effect on moisture if there's a lot of sweating involved, or a lack of moisture. It could decrease the variability of the seating positions that a person can tolerate based on their blood pressure. There are lots of autonomic, that like your cardiac function, for example, all of those things can affect your tissue perfusion. So then if we go to people like Lorinda who have had a previous pressure injury, if there's scarring, if there has been a previous pressure injury at that site, then there is increased risk of pressure injury there. The tissue tolerance has decreased. It's not as strong or as resilient and never will be. Bowel and bladder dysfunction can increase the moisture concerns. And then people with spinal cord injury often have quite a bit of muscle atrophy, and we know that muscle mass is protective against pressure injuries. And so if the loss of that muscle atrophy is really pronounced, then the tissue tolerance decreases even more. So when we're looking at this whole picture for folks with SCI, the deck is often stacked against people like Lorinda, where it doesn't take much. It doesn't take as much as we think. It doesn't take as much time as we think. And Lorinda, I'm going to ask you to tell us sort of the story of the development of that pressure injury for you, if you would.
Absolutely. So it just started off as a bruise with a mild, like a scratch on my right IT bone. And I went home from my friend, like the weekend we had away, and I did a skin check and I saw the initial scratch and the bruise. And I just started resting as much as I possibly could. And I was laying on my stomach quite a bit, just trying to take pressure off of the site. And I did make an appointment to see my family doctor. Unfortunately, they weren't maybe as well versed in pressure injuries with spinal cord patients. So I didn't get any referral or anything to the wound clinic, just was kind of told to continue to rest at home. And I think this is where the whole iceberg analogy comes in, because I think what was shown on the outside was totally different than what was going on underneath the skin. And I think there had been a lot of substantial damage. So I kind of spent that summer, I was supposed to be working at a summer camp, but I decided I was just going to rest and try and heal as much as I could on my stomach. I increased my protein, did everything that I thought I could do to possibly heal it, but it just wasn't healing. And it would almost close and then it would open again. And it was just kind of a back and forth. So finally, in December, it was
I'm hearing it.
Still quite severe and it wasn't healing. And at that point, my family doctor referred me to the wound clinic, which I just wish I had gotten into them so much sooner, because my story would have probably been so different. But once I got in with the wound clinic and they started debriding the wound, we realized that we had a much bigger problem than what was presenting on the outside. And I basically had like a gaping hole that was tunneling. And we did try to do electrical stimulation, but what I feel like is that the wound had been too far. It had been not cared for enough in the initial stages. So it just felt like we could never really catch up and heal it. I did try wound vac as well, but nothing was really healing it as well as we could. And I was just severely depressed at this point. I'd spent like half the year just on my stomach, just at home, having all this trauma, emotionally, physically, and mentally. I was in a pretty dark place. And I would only get up in my chair for like the necessary tasks. And I was trying to do my schooling, so I was able to do some of that online, but I was just very isolated, laying on my stomach in my bed at home with my parents. My mom was learning how to be a wound care nurse and just learning from the community nurses on how we could get this bandage, like we bandage it and try and heal it as best as we could. And nothing seemed to be working. So at that point, it was decided that I would need to get a consult for a flap surgery. And they were kind of hesitant to do a flap surgery because the recovery time is quite intense. You're just on your stomach in the hospital. You're not allowed to put any weight on it. But I was kind of in the mindset that I'm doing that already. I have no quality of life at this time. I'm just at home anyway. So I kind of saw the flap surgery as like the light at the end of the tunnel, that if I can get this wound healed, get the flap surgery done, rest it for the month or 6 weeks afterwards, that I would be able to get back to a normal life. So I also ended up developing osteomyelitis, and I did end up needing the flap surgery. So I was very grateful to get it. And then I had the recovery time of that.
Awesome. Thanks, Lorinda. And we'll talk about that recovery and your surgery in a few minutes when Hardeep hops on. I just wanted to point out a couple of things about Lorinda's awesome story. Thank you for sharing that with us. I think when we're looking at this picture here, we see a couple of things from that story, right? We see the mechanical load and the inappropriate equipment situation. I think we always talk about, you know, the cushion goes where the bum goes. And in this case, the cushion didn't go where Lorinda's bum went, but she didn't have any sort of inkling that this one time was going to be a problem for her. But I think if we go down to the bottom here and we add in moisture, Lorinda, you were in the water, right?
Yeah.
Yeah. So like that also increases the damage that this mechanical load can add onto your tissues. And it's possible that there was a deep tissue injury right from the beginning, because you said you saw a bruise, which is pretty classically that, like you said, the iceberg, the damage under the skin that then eventually shows itself. So I think, you know, like there are lots of those like little pieces of the risk factors in that one little tiny story that then affected so many years of your life. Thank you so much for sharing that with us. I really appreciate it. Let's just talk very briefly about how we as a group, both, you know, care providers and patients and people with lived experience, folks with SCI, can prevent pressure injuries. Number one, like Lorinda said, she did a skin inspection that day and she found her skin discoloration. A skin inspection at least daily is important for life. but also for us here caring for folks in the hospital, super duper important. And we always say, look in the nooks and crannies, right? It's not just about bums, it's about everything. The support surfaces, you know, we're talking mattresses, cushions. The cushion should go where the bum goes. Nobody should be placed on a hard surface. This is something for folks that work in hospital. We like to put people on hard surfaces to send them to tests. And this is a practice we should probably not do for people with spinal cord injury. The keep moving, it's really broad. The keep moving generally is talking about all of the management of the mechanical loads. So we're offloading, we are repositioning for offloading in bed, we're rotating medical devices, we are medical devices that we can't rotate, we're trying to offload in some sort of way with a protective foam or a device, securement devices. It's really about trying to make sure that we are manually managing that the load so that we're not getting too much blue arrow so that it overcomes the green arrow at the bottom. Incontinence management is really about all moisture. So we have to remember, moisture doesn't just come from incontinence, it also comes from lakes and pools, could come from spills, could come from sweat. You know, like if you're gonna ride the log plume at Disney World, that's moisture, right? So moisture can come from any wet location, and those are all things we need to think about. It's not just about incontinence. Nutrition and hydration. Lorinda, you said you were like eating tons of protein, you were doing your very best, and nutrition and hydration have a huge role to play, especially in healing. But as we saw, like sometimes it's not enough, so we have to do all of it. The risk assessment obviously is very important, like your Braden scale or a Skypus or something like that. But we know from studies that we've done in Alberta Health Services that a lot of people think that they've done pressure injury prevention when they've done a risk assessment. So that's why it's kind of not highlighted in the big list. And last, but certainly actually first, is for us, for healthcare providers, to remember to thread patient and family engagement and education throughout the whole process of pressure injury prevention, especially when we're doing sort of the handoff from a little bit more of an early learning process to an independence process. So that's it for me. I'm going to hand it over to Hardeep, who's going to talk to you about management and treatment.
Wonderful. Again, Lorinda, thank you for sharing your story. So when you kind of shared the journey from when you first developed the injury to how that year went, it was interesting because you went through a lot of the different management and treatment options that we have. Like you said, if some of those had been started earlier, then the outcome may have been prevented in terms of a flap surgery, and the wound may have healed on its own. So again, anytime we look at management, the first thing is always prevention. All of the things that we've just spoken about with Julie, with offloading, looking at surfaces, moisture, and wound dressings, that continues even after a wound forms. If the wound then develops into a stage 3 or stage 4 pressure injury, we have a couple of things that Lorinda both tried. So we have wound vac, or a negative pressure wound therapy. And again, that's really to provide a subatmospheric pressure to the wound, and it helps to reduce inflammation and promote wound healing and angiogenesis, so new vessels forming, discarding the old waste cells, and then providing a cleaner surface for new tissue to develop. Kind of the standard practice that we use, but very expensive. People need to have home care put it on, or if they're in hospital, 3 times a week it needs to be dressed and changed. It loses suction often. So a good therapy, but also has its negatives. The second option is something a little bit more new, is electrical stimulation for wound healing. And it's interesting to hear that Lorinda did try this, but maybe a little bit later in the course. So electrical stimulation is interesting. If we go to the next slide. So what this, the basis of this is something called galvanotaxis, which is the promotion of an electric field basically over the surface of the wound, and it promotes different cells to come into the wound to heal at different stages. So you put on an active electrode over the wound and a dispersive electrode that's further away from the wound. And then that provides the stimulation or the electrical current needed for different cells to come in. And again, this brings in new cells for blood formation, for angiogenesis again, so for blood vessel formation, and it increases your inflammatory cells to speed up the wound filling in. So the time for closure has been increased when people do use electrical stimulation. But importantly, it needs to be used within the first 6 months of the wound forming. So I don't know if that happened for Lorinda or not, whether it happened in the first 6 months or not. But it's important that we consider this, and the polarity changes every week because every cell has a different charge, whether it's positive or minus. So that's why we change it every single week. So yeah, an interesting another adjunct treatment that we do have between the two. There is contraindications for using it, which is basically things like pacemakers and other devices. If you've got metastatic cancer that's not treated, or untreated osteomyelitis is something else that is a severe contraindication for this. So can we go to the next slide, please? So before we go to this slide, Lorinda, I did want to ask you then, so you told us about the journey up until surgery. So now can you tell us a little bit about post-surgery? So you had the flap. I'm assuming you most likely had a musculocutaneous flap over the IT. And then, so what happened afterwards? So right in that acute period, what was the process?
So the acute period was basically I was at the Rocky View General Hospital here in Calgary, and I was just laying on my stomach for the first, I believe it would be like the first 2 to 3 weeks, strictly on my stomach, no weight bearing, just making sure everything had every opportunity to heal and be healthy. I also was still on a high protein diet, and I'm not going to lie, it was mentally really hard because you are basically on your stomach. So you can't leave that. I couldn't leave the room. I couldn't leave my bed, had to do everything, eating everything while lying on my stomach. And I think mentally, I just had to get through that time because that was kind of the only way I could move forward with my life and get back to normal life, was if I gave this wound every opportunity to have a successful flap surgery. So just trying to keep myself busy and entertained while just laying on my stomach. And yeah, it was mentally was trying, but we did get through it. And I'm very grateful for all my friends and family who were a huge support, and all the doctors and the nurses and healthcare aides who did everything they could to get me through it. So yeah.
Yeah, thank you for that. So if none of those things we spoke about worked, then the option is flap surgery. So a reconstruction surgery that needs to be done usually with plastic surgery. So when you get to this point, the decision needs to be made, is a particular patient appropriate for a flap surgery? And that's a very important question. And we feel strongly that this is something that needs to be done in an interdisciplinary fashion. So we need to have lots of different people involved in that process. And so here, this is something that we've kind of developed and talked about. All of these different people should be involved and speaking to the patient prior to them going under the flap procedure to make sure they're an appropriate candidate for the procedure, and to make sure that they understand what's going to happen in that post-op period that Lorinda's just spoken about. As you just said, very testing both mentally and physically. So this interdisciplinary team should be involved pre-op and post-op. Very, very important. So I'm glad to see that Lorinda got through that period. And if we go to the next slide, what she went through was very common. Usually you get 3 weeks of bed rest, and then progressive sitting begins, which is usually at 10. You start with 10 to 15 minutes, 2 or 3 times a day. And then every day you'll increase by 5 to 10 minutes if the wound is improving. And this should really be standardized across really all of North America or the world. And what we know is it's not, unfortunately. There's lots of local knowledge available, but there's no standardization currently. So some centers are not doing this. If done correctly, it will take up to 5 to 8 weeks, depending on how quickly the wound progresses. And again, this is very important so that the wound has a chance of not recurring. recurrence rates with pressure injuries are at 40 to 60% of the time they recur. And we know that these wounds, the skin that develops there afterwards is never as good as the initial tissue. So that transplanted tissue that's moved there, the muscle never fully is the same as it was previously. So that gluteus muscle, when it's flapped down, actually loses some of its muscle mass that Julie talked about earlier. And because of that, you develop some fibrosis and you lose some of that cushion, and the blood supply is never the same. So therefore, there's always a higher chance of that developing into another pressure injury. So really, education is big, and this is where Lorinda's done so well, is arming herself with knowledge and taking on what she was told from peers and from the healthcare team that she had to try and prevent this from happening again. So really well done with that. So the biggest thing there is preventing recurrence from happening again. So just to wrap up, we've only got 5 minutes left. I'll just hand you over to Julie again, just to really ask a final question over to Lorinda. Oh, you're muted, Julie.
Sorry, I moved my mute bar to behind like 3 other things. My question for Lorinda is kind of what this slide is about. How has this experience of this wound changed your perspective and your action on pressure injury prevention, about your proactivity in that area?
I'm ashamed at how lazy I was before I had this wound. I didn't realize how serious they can go. I almost had that mindset like, oh, it'll never happen to me. But after going through this experience, I feel like I'm just so proactive. Throughout this experience, we realized that the 2-inch ROHO profile cushion that I was sitting on, my IT bones were actually sliding through the ROHO cells. So I needed to be on a 4-inch high profile ROHO cushion. I've dialed in my seating. Due to nerve pain, my whole pelvis had shifted, so I had more weight on my right side. But with proper seating now, we've kind of brought it so that my hips are even and flush and there's no extra pressure points. I've tried to eliminate as much pressure as I possibly can. I have a ROHO everywhere I go now is my motto in life. And recently I just was on a hike and we had to cross over this wall, and the friends I was hiking with made sure a ROHO was underneath me while I was hiking. And I just try and be on every seating space, I have a ROHO on my showering, on my bed, on couches. There's just a ROHO cushion around to try and prevent it. I also was introduced to the Mepilex bandages. They act as a second skin. So I put that over my flap surgery site just for extra cushioning and protection. Like doctor said, the skin is not the same, and I do have muscle atrophy. I've been in a chair now for over 10 years. So I am just trying to be as proactive and preventative as possible. I do skin checks. Not going to lie, I get anxiety every time I do a skin check because I just have this picture of what I saw when my wound was at my worst, but it empowers me now. So I know where my skin is at each day, and I know if I need to be in my chair or be doing more offloading. Just knowledge is power. And I've just kind of been a voice to other people who are dealing with pressure sores, just to give them my story and be a warning to them, because I truly would not wish this journey on anyone. It's really hard. And I just hope that other people can prevent pressure wounds from getting as bad as mine and just really heal them before they get in that danger zone. So.
Thank you so much, Lorinda. Everybody in the chat is really grateful for you sharing your story. I am very grateful, and I know Hardeep agrees, and we're so happy that you came to have this sort of panel discussion with us today. Do you have any questions for us?
Julie, is that you're asking Lorinda if she has
I was asking Lorinda first, but then we will have open questions. Yes, of course.
I can't really think of one at the moment, but I'm sure I do. Okay. But I'll send you an email later if I do.
You can
Thanks for having me and for listening to the experience, and thanks for all you guys do to prevent these wounds from happening to others.
Well, thank you guys.
Thank you, everyone.
We do have a few questions. Don's gonna go ahead and try and moderate those for you guys.
There was a comment. Kelly made a comment. E-stim will fail to progress a wound healing in the presence of osteo. Need to treat the osteo. There was some question around whether or not AHS has these. And Kelly answered Calgary, Edmonton, Lethbridge. And Janie, I'm sorry if I said your name wrong. The units aren't readily available. We have struggled with wanting to use them, but not having the equipment. So I think there's an opportunity for discussion. There are no specific questions. I do have one for Lorinda. Did you reach out to your physiatrist/clinic for help? And did you know who to ask for advice and help?
So now that I've gone through this journey, the first thing I would have done if I could go back in time is I would have gone to my physiatrist and to my spinal cord injury team, because they have all the wealth of knowledge and all the connections. And I think that was initially a mistake I made, is I just went to the doctor and they just maybe didn't realize how serious it was. So yes, always make sure you're in constant contact with your physiatry team, because they have all the connections, they have all the knowledge in spinal cord injuries, and they can direct you to the right resources. So I wish I would have done that back in the day, but.
Yep, and that's why we're here in Edmonton and in Calgary. Anything regarding your spinal cord injury, we're the first port of call. So everyone should feel free to contact us for anything.
Thank you. I have one from Justine. As a nurse in rural setting, would we consider sending someone to a spinal unit to be considered for the E-stim before moving to a flap consideration?
Sorry, can you just repeat that? I broke up.
As a nurse in rural setting, would we consider sending someone to a spinal unit to be considered for the E-stim before moving to a flap consideration?
Unfortunately, the units that we have, the rehab units, are not set up for that. We take patients that have, if they develop a wound in acute care and they come to the unit, then we can give them E-stim. I know in Calgary, they have it more in home care. The home care with Kelly is set up excellently there, and they do have it available. Unfortunately, we don't have availability for E-stim in rural areas. What you would need to do is have that patient sent over to their physiatrist if they're a spinal cord patient, to assess their wound and to come up with a treatment plan. And then the spinal cord physiatrist would bring in a plastic surgeon for assessment if needed. What we're hoping to achieve is an interdisciplinary clinic that we just, like I spoke about, where there's a whole group of people all together looking at this wound, trying to heal it before we go to surgery. Because surgery really is the last resort here. It's much better if the body heals itself rather than having the flap done.
Hardeep and Kelly, I have an additional question to that. Is there a way for wound nurses or physios, OTs, physicians, professionals in outlying areas, if they want to become competent in E-stim, is there a way for them to do that if they can acquire the equipment? I know what I would do, but
yeah, and I think I probably can answer for Kelly on that one. She's probably writing something, but Kelly is like the person in Canada for E-stim, so she's an amazing resource, and she's always willing to educate anyone that's willing. So if there's a group of people willing to undergo education, she could set up a virtual session and give you some knowledge and training. And then we could figure out ways to get E-stims out into the communities if that's something. It needs to have the appropriate education, because I've seen it go wrong where people haven't been educated correctly, and then things like the actual what's it called, like the electrodes have been left in the wound and developed infections from that because the knowledge was not there. So it just needs to be done in the appropriate manner.
Kelly's amazing. She was a big part of my story in helping me get better.
Thank you, Lorinda, and thank you, Hardeep. I just want to say that e-stim, you have to fix the cause. So e-stim alone will not fix the pressure injury. You have to fix the source of the source. So if they have to be offloaded, nutrition, interdisciplinary team, and when that is sort of organized and you've made sure there's no osteo, then you can go on and do e-stim.
Yeah, it's one of the modalities we have for treatment, but yeah, Kelly's right. Everything else needs to be in line.
So there's about 3 more questions. We only have about 5 minutes. I'm sorry, I don't want to cut you guys off because it's a great conversation. Mary's just asking though, how does pressure offloading recommendations when in a wheelchair change from the acute SCI to more chronic? E.g. 2 minutes every 30 minutes at the start. How do you know when you can change that? Should you ever?
Yeah, interesting question.
It's a great question, Mary, and I think the answer is we actually do not know. The two Q2H, the 20 minutes, every 15 to 20 minutes, like that, it's all a guess. It's all everyone's best guess at this point. And until we have an internal device that can measure the tissue pressure next to the bone, it's anyone's best guess, honestly, which is probably why we're not perfect at it.
Yeah, what I'd say is generally, as what the advice that I usually give my patients is, as they're going out, is just to start to increase that slowly. And it's going to be different for everyone. Everyone's tissue pressures are different. Everyone's gluteus muscle is going to be different. Their pressures, how they sit, their pelvic tilt, everything is different in every patient, right? So you just increase your time slowly, continuing to do that pressure relief for at least 2 to 3 minutes to allow the blood flow to come back in. And then you're doing skin checks regularly. And as soon as you see the first signs of any erythema that doesn't go, like that first stage 1 type, then you know you need to back away from what you're doing. So I think it's something that you just have to, from an individual basis, start to increase.
Yeah, it's trial and error at best.
Okay, we have one more. I have 2 people with their hands up. If you could just send those in the chat box, if able, that would be great. Then we can send them to the right person. Bean is asking, can someone please speak to the nanotest cream for wounds that is developed in Calgary? Does it really work? And Dr. Ho has offered to answer that.
Yeah, thanks, Dawn. Bean, basically, I'm currently actually working with nanotest on a study using that NanoSelf product. And so it is actually being evaluated within AHS. And so there are some good preliminary results, and we're hoping that it will become available. But let's analyze the results first and then see where we go from there. Thank you.
I'm just having a look. I had Vivian and Michael raising their hands. I don't know if we have the chat option on here. So if anybody else has anything else they wanted to put in the chat box, I'm happy to ask it.
I could see James has asked a question here about, it's the what do I put on it question. And I think I can answer this question about what would you recommend for stage 1 or stage 2 pressure injuries? And I'm going to be controversial and say it doesn't matter, because you have to treat the underlying cause of a pressure injury. And if you're not going to offload it, it doesn't matter what you put on it, it will not heal. So whether you decide to treat a stage 1 doesn't necessarily need an actual dressing, but could go with a preventative foam like what Lorinda has been doing. That there is some good evidence to say that using a preventative foam dressing as an extra bit of cushion actually can provide some protection. But for a stage 2, for example, you could put a cheap and dirty dressing on it. You could cover it with barrier cream. You could put the fanciest, most expensive whatever on it. I mean, you know, maybe there is a miracle in something like nanotest, but even that probably will not be able to heal something that is still under pressure. So if we can't offload the pressure, You could put nothing on it, or you could put the most expensive thing on it, and it would not make a difference.
Thank you guys so much. That was great. I just have one last one, and then we'll have to switch to the next topic. Is nanotest the same as triad? No, it's not. Okay, thank you so much.